I have the right one? 2.2?
Yeah.
Okay.
Good morning, everyone. Welcome to the House Healthcare Committee on Wednesday, February 15th. We are today focused again on COVID flexibility language. Those watching online, the draft 2.2 is posted under our committee page for today. And we're going to start with Sarah Teachout with Blue Cross Blue Shield. Welcome.
Good morning. Thank you for having me.
Yeah.
If you don't mind, I'd like to spend just 2 minutes introducing myself and Blue Cross because I haven't had the opportunity.
You've been on the side, but you haven't been in the chair, so please do.
Great, thank you. So I'm Sarah Teachout. I'm the Director of Government and Public Relations for Blue Cross and Blue Shield of Vermont. I have been there for 5 years. Prior to that, I spent 16 years working on tax policy in the Joint Fiscal Office here in the legislature. So a little bit of a change. Blue Cross and Blue Shield of Vermont is a local, independent, not-for-profit Blue plan. So there are 34 Blue plans nationally. One of them is a for-profit. That's Anthem Elevance. There's about 4 or 5 that are regional plans, mostly on the West Coast, a few here on the East Coast. And then there's 12 state-only or sub-state plans, of which Blue Cross and Blue Shield of Vermont is one. So we're located in Berlin, just up the hill. We have about over 400 employees, and we only sell insurance here in the state of Vermont. And then our relationship with the rest of the plans is a little bit like a franchise. So, and we share our network nationally, which is what allows people who have Blue Cross and Blue Shield of Vermont insurance to access services all over the country and internationally. So just quick high level for you all, and happy to answer questions if you ever have any.
Does anyone have any questions now?
I have a question on that.
Sure,
Very
sure.
much so.
Yeah.
So you're not a for-profit company?
No.
You are not?
No, in fact, we're specially created in the Vermont statutes, and we are sometimes called the insurer of last resort here. It was more meaningful before the ACA, but Blue Cross and Blue Shield of Vermont used to and still does in certain areas. If a company goes out of business, if people lose their health insurance here in Vermont, they can always come to Blue Cross. We are required by state statute to cover them.
So did the state pay your salaries?
No.
Where does that come from?
Premiums.
Okay.
Yep.
All right. So you're not for profit, but you can profit from premiums.
We call it margin, but yes, we can have margins.
Okay.
There's a board of directors made up of Vermonters.
So in my pea-sized brain, why are we in this arrangement? Why wouldn't it just be a for-profit company come in and offer insurance?
Well, we could spend a lot of time talking about that.
Never mind.
It's a little bit of the history of the Blues system, which is unique, and then a little bit.
Yeah.
All right, we'll plan on once we get through budget and everything, we will absolutely have Blue Cross Blue Shield.
Yeah, it just struck me that this was the case. So
I think a lot of people don't know that. So that's why
I didn't know until recently that it was established in state statute. So that was a new one for me.
yeah.
Leslie?
So it's new to me that you have 400 employees, which sounds like a big organization by Vermont standards.
Yes.
How many people do you cover with that workforce?
Yeah. A little over 200,000. And I guess the other thing I should say, 1 in 3 Vermonters has Blue Cross and Blue Shield of Vermont insurance. And it's because we offer insurance in every single marketplace in the state of Vermont, which is also a little unusual. Most other carriers target segments. So we provide qualified health plans on the exchange. So individual and small group plans. We offer large group fully insured. So that's the fully insured marketplace. We offer self-funded health plans. So usually large employers, but it can be smaller. And then we have Medicare Part D, Medicare Supplement, and Medicare Advantage. So
That you administer?
Medicare Part D, we offer in conjunction with a New England consortium of states.
Okay.
So, and then our Medicare Advantage is a partnership with Blue Cross and Blue Shield of Michigan. That's how we offer that one. But everything else is Vermont only.
Thank you, Sarah.
Yeah. So I'm looking at section 2.2, and there's a few pieces in here, but you've taken a lot out that have to do with commercial health insurance. So I'm just gonna
So you can tell us page and line number.
page and line. Okay, so page 4, line 10, section 6. This is provider enrollment and credentialing.
Okay, everyone there?
Lori, where are we? What document?
So they're under today's date, go to the draft 2.2,
Gotcha.
and then now we're on.
Okay, we're on that draft.
Or line 6 and 10, section 6.
Great. So what you're doing here is extending for another year, sort of some permissive, relaxed provider enrollment requirements. I wasn't going to get in and explain what credentialing is. I don't believe that this is being commonly used at the moment, and we already expedite requests to credential providers if necessary. So if you want to continue this policy, I think that's fine.
Okay.
So,
And we'll hear from Diva on this as well, so.
right. So then the next one is the section 8. So it's
Same page.
page 4 also. So actually you're skipping from section 6 to section 8. So that's what's confusing here. And this is DFR emergency rulemaking, and you're giving them authority through another year. I don't know why you're switching the date from April to March, but to have COVID-specific emergency rules. So this is permissive.
Can
And
you explain what you mean by permissive?
permissive. So it's not, you're not requiring that the Department of Financial Regulation extend the COVID regulations or promulgate new rules, where you're just saying that they may if it's necessary. So I think we're fine with permissive legislation. We would, just to be very clear, oppose mandating in statute a continuation of the COVID emergency rules. We believe that we're moving into the next phases of COVID, and we need to, work through these processes where COVID eventually becomes part of the sort of suite of health issues we have to deal with as a community.
Okay. And we will hear from DFR on that too.
And I think there's one other piece where okay, so page 8, line 17F, you are saying that healthcare facilities, health insurers, and Vermont Medicaid shall consider deemed licensure, certification, or registration pursuant to the requirements of professional credentialing and licensing. I am not, because this is, again, permissive, you shall consider, we're happy to consider it. We have to credential to maintain our NCQA accreditation standard. So I think it would be very difficult for us to give up control of some of these things and maintain our accreditation. We do, I will say, some of the large hospital facilities like UVMMC self-credential, and we accept that because we have an agreement with them to do so. So we have, I think, worked with some systems to try and make it a little easier, a little more efficient, and we're willing to look at that.
Okay.
But I would caution that we can't go too far with
Okay. And it is permissive, not,
permissive, so that's,
It's not permissive.
it's not
Sorry,
permissive.
it's not permissive, just to be clear. It says they shall consider deemed licensure, et cetera, as sufficient to meet. So
Okay.
they shall treat it as sufficient to meet.
okay, well then I misread that, and we would like it to be permissive because we are worried about our accreditation.
Because the consider is the confusing word.
Yeah.
Right, in this case, it means they shall consider it as sufficient.
Okay, so you would like shall removed. Is that how it would?
I'm sure Jen can fix it.
I think your intent
Okay.
is, I understand
Change that.
from the Jennifer Carvey Legislative Council,
Thank
I
you.
understand from Blue Cross, they would like it to be permissive. I think
Yeah,
once I know
policy
what your
change.
intent is, I
Okay.
can advise for it.
Okay.
And then I think you've removed some pieces that we requested, so we appreciate that. I'm looking for them, so I'm scrolling quickly. There was a piece, I'm not seeing it right now, on requiring people to have more than a 30-day
Yes, that's been.
refill. So we appreciate that you're allowing that to go through. And then the piece on remote witnesses, I don't think we have a position on.
Okay, and that actually is Human Services.
Yeah. So
Okay. Great.
pretty short time.
Yeah. Well, thank you,
Okay.
Sarah. We appreciate that. All right. And then, of course, 'cause I'm always confused. I think Sebastian, you're next. Does that work? In person.
In person.
Nice to see you.
Good to see you all. So Claire, I sent a slide deck. Could you put that up on the screen, please? So just to frame.
Introduce yourself.
Oh, that's right. Sebastian Orduego for the Department of Financial Regulation. So just to frame the department's testimony this morning, I've prepared a slide deck that briefly summarizes all of the federal and state coverage requirements for COVID-19 that were put in place from March 2020 onward. The next slide, please. So first I want to talk about some of the federal coverage requirements. These requirements sort of form the basis of coverage that all plans, including self-funded employer plans, were required to provide during the COVID-19 public health emergency.
Okay.
So next slide. What we are talking about with respect to federal law is three major pieces of legislation. The Families First Coronavirus Response Act, the CARES Act, and ARPA. And all three of these statutes have a lot of regulations and guidance that was issued by the Departments of Labor, HHS, and the Treasury. Next slide, please. So what federal law requires with respect to testing is that health plans cover diagnosis and testing of COVID-19 without member cost sharing. That is, no premiums, deductibles or copays. Plans can't require prior auth or require members to have symptoms or suspected exposure to COVID-19 as a condition of coverage. And most recently, starting at the beginning of 2022, plans were required to cover members for the cost of up to 8 over-the-counter COVID-19 tests per enrollee per month. Plans were also required to cover out-of-network tests, reimbursing testing claims at up to the cash price that the provider publicly posted on their website. Next slide, please. So even though the federal statute provided all of these financial protections for COVID testing, there is no corresponding federal coverage requirement for treatment. So any applicable member cost sharing applies to the treatment of COVID-19 for under federal law, just as if it were the flu or any other condition. Next slide, please. So with respect to prevention of COVID-19, federal law requires health plans to cover all COVID-19 vaccinations, including boosters. And what I mean by all COVID-19 vaccinations is all vaccines that are currently approved by the Food and Drug Administration. And they're required to provide this coverage without member cost sharing or prior authorization. Plans can't require cost sharing for office visits if the primary purpose of the visit is for vaccination. And they have to reimburse network providers the negotiated rate for vaccination services and out-of-network providers a reasonable rate. And an example that's cited in the federal guidance as a reasonable rate is the Medicare reimbursement rate. Next slide, please. So In Vermont, we also put in a number of coverage requirements for health insurance plans that are regulated by DFR. Next slide. So in Act 6 of 2021, you gave us authority to adopt emergency rules to expand health insurance coverage and waive or limit cost sharing requirements directly related to COVID-19 diagnosis, treatment, and prevention, and to suspend health insurance deductible requirements for all prescription drugs, except to the extent that it would disqualify high deductible health plans from eligibility. And then as amended by Act 85 of 2022, Act 6 gave us the authority to keep these emergency rules in place until March 31st of this year. Next slide. So since March of 2020, we have adopted a number of emergency rules. The first protections we put in place were insurance bulletins 209 and 210 right at the beginning of the pandemic in March of 2020. And that was followed by rules 2020-01E, 2021-01E, and 2021-02E. And these emergency rules have basically kept the framework that I'm about to go through in place from March of 2020 until now. Next slide, please. So under our emergency rule that it's currently in place, this is H-2022-01E, insurers are required to cover certain COVID tests without member cost sharing. And in Vermont, we were particularly concerned about COVID tests that are combined with other tests, such as the Fluvid tests. So our reg specifically calls that out. We also require coverage of any qualifying vaccines without member cost sharing, consistent with federal law. And the big difference between what we require in Vermont and the federal requirement is that we require coverage of medically necessary COVID-19 treatment without member cost sharing. And this includes inpatient and outpatient treatment, any medication that's prescribed or administered in the course of treatment, and emergency and non-emergency ambulance transport. Next slide, please. We also require coverage of out-of-network services related to COVID-19 without member cost sharing. Similar to our general regulation that requires out-of-network coverage in certain cases, insurer liability is limited to the reasonable and customary value of those services, and insurers have the responsibility to respond to, defend against, and resolve any provider request or claim for payment that exceeds the amount it paid or reimbursed. Next slide. So our emergency rule has been based on the fact there is a federal public health emergency. So on June 14th of 2021, Governor Scott ended the state's COVID emergency, and the Department of Health and Human Services has announced that on May 11th, 2023, that the federal public health emergency will end. And with the end of the federal public health emergency, all federal requirements that are related to coverage of COVID-19 testing and vaccination will also end. So with respect to the bill that's been being proposed, the department does not oppose having continued authority to emergency emergency rules. I think we've all seen how dynamic COVID can be, and think having that authority in place will allow us to respond if there is another outbreak or another variant or some other unanticipated circumstance.
Art?
Yes, thank you for the testimony. Do we know how many other states are going to, man, we probably don't know, are going to continue some form of emergency legislation?
I think we are the only state that has its emergency COVID rule in place.
Really?
Yes. For a little while, it was just Vermont and New Mexico, but now it's just Vermont.
So we're the only ones that have this legislation in place?
So it's on an emergency basis,
Right,
yes.
right, okay.
So again, it is you're okay with having the authority from
Yes.
us. It is not requiring you to do any of this.
Yes.
Correct. Okay. Any other questions for Sebastian? It was very helpful to walk through what we had done in the past as a reminder.
Yes, and I hope it was also helpful for you to see what the feds had done too, as just background knowledge.
Absolutely. Great.
Great, thank you.
Hold on one second, Leslie.
So maybe I missed it, but so what sections of the bill are you thinking about when you talk about the emergency? And maybe I'm not getting it. It has nothing to do with this bill, is what you're saying, or where?
So in
No. Sebastian, do you want legislative council to refer to the sections? Or are you good? I don't know.
I'm good. I
Okay.
had scrolled down on my document to keep up with what Sarah Teatout was.
Oh, okay.
Now I'm trying to scroll back up without a mouse. Section 8.
So hold on, let's make sure
So
we,
it's section 1 of the bill, but it's section 8
Oh.
of Act 91, so it's that confusing way of finding the section that's on the bottom of the page, starts on the bottom of page 4.
stage 4. Okay. So really on the top of page 5. Okay.
Yes. So in subsection B1, what I'm referring to with respect to emergency rulemaking authority is that authority because the legislation states that the department shall consider adopting and shall have the authority to adopt emergency rules.
In case you need to. That's what you're talking about,
Yes.
that section right there. Thank you.
Yep.
That's helpful.
Thank you.
Great. Thank you, Sebastian. So I see Shayla. It's your turn. Perfect timing.
Be very quick.
Welcome.
Thank you. Hello, everybody. I'm Shayla Livingston from the Agency of Human Services.
And what are your thoughts on the COVID flexibility bill?
So we deeply appreciate you guys reviewing the COVID flexibilities. We support extending the existing flexibilities. We do not use them frequently. We are using one right now in terms of the rules. So this is in the first section of the bill. We're using it for a rule around home health. And we would like to continue to do that as we work with them on a more permanent solution for the current workforce issues we're facing. So we appreciate that and we support it. The Department for Vermont Health Access does have a question around the goal the committee has for section 6. So we just, otherwise they're supportive of the changes that you have here, but we're just not clear what the committee is trying to achieve with that section. And we just want to have clarity on that before we give the final go ahead.
So it's page 4, line 10, section 6. And it's the Medicaid and health insurers providing enrollment and credentialing flexibility. And so this was a suggestion from the Healthcare Coalition that they wanted to have this extended for just a year for the same reasons they have wanted to in the past to be able to allow that flexibility.
All right, I'll connect with Devin then on that.
Yeah.
And just make sure Diva's totally fine and I can send an email.
Okay.
Confirming that.
That'd be great.
Once I do.
Daisy?
I'm looking for which section it's in, but there's something in here about advanced directives. Lori, I know you mentioned that that would be taken up in human services.
Yes.
But Shayla, isn't advanced directive something that we do in
The health department. No.
and DMH as part of suicide triangle, zero suicide program?
Oh, okay.
I believe it is.
I
Deputy
would
Commissioner
have to get back to you on that one.
Probably confirm that.
Okay.
But I believe that doing advanced directives is something that we are training our mental health clinicians to do so that people with serious mental illnesses have that in place. So it's not necessarily a tool that people use as part of aging or planning for that, but it's something that we can use to prepare in case you have a serious mental illness and are unable to make a choice because of that. So I wouldn't want this to cause hindrance for that.
I will check with her as well. I know the health department is aware of this section. But I will check with DMH as well, because I don't think that's on their radar. Yep.
So we will wait to hear back from Diva, and otherwise you're okay with the language as it is.
Correct.
Great. Wonderful.
And I'll get back to Rep. Rebecca.
Yep.
DMH.
Thank you. All right, thanks for your time.
Thank you.
Have a good day. Right, now we're going to the folks on Zoom. Susan, Michael Barber, and Russ. Hi, Susan, how are you?
Hello. I'm sorry I'm not in person
No worries.
like everyone else. I'm having a little FOMO here. Missing out. So I'm joined by Michael Barber, who's our general counsel, and Russ McCracken. Mike Barber may need to get in the car and go to a dental appointment, but I think we're gonna get this done before he has to do that. So that's why they're both here.
Wonderful. Do you want to, are you frozen? No, you're not frozen. Do you want to direct us to, do you have a general
Sure.
statement, or do you want to direct us to specific sections? Or
Sure.
both?
So for the record, I'm Susan Barrett. I'm the executive director of the Green Mountain Care Board. And I'm joined, as I said, with Michael Barber, our general counsel, and Russ McCracken, one of our staff attorneys. And we are looking at section 5. It's on page 3 of version 2.2, and it starts at line 11.
So page 5, sorry, say it again, page 5.
Page 3, nope,
Page
page
3.
3, section 5.
Right, line 11.
Line-
Okay.
Was on version 2.2. So if I'm off, let me know, but that was what I just looked up.
Yes.
And
Yep,
great.
That's perfect.
So the board is in support of extending the language in this section for another year, the flexibilities around our regulatory processes for COVID flexibilities. So that is our statement. It's pretty short and sweet. And if you have questions, I can answer those.
So I do know that VAS had testified that they were going to work with you on some language. And VAS reached out to me last night and said they would be getting back to us today. So I just want to confirm, you are fine with the language as it is, extending it 1 year?
That's correct.
Okay. And that is the only section that pertains to Green Mountain Care Board?
Yes, it is.
That was easy. Any questions? It's gone a lot faster than I thought it would. Any questions we all good with where we are on that? Great. Thank you all very much for coming. Enjoy your day. So, Mike Fisher, healthcare advocate, did you want to testify?
I think I did.
Okay, so you weren't on the list. I apologize. Would you like to come up and testify? Are you ready now, or do you want to?
I think I already testified. I think
You did? Okay, great. Sorry.
you did not miss me. You already checked me off.
Okay,
Clear.
Obviously, I forgot. Okay, so where are we with this then? We need to hear back from Diva on section 6. It appears everything else everyone was supportive of except page 8, line 17, where Blue Cross Blue Shield wants it to be permissive.
We need to hear back from Boz on section 5.
Yes, when we need, yes, so we need to hear back from Voz on section 5. Diva on section 6. And we'll want to have the Healthcare Coalition come back on section 17F, which is on page 8. Since Blue Cross Blue Shield wants to change it to be permissive versus what the Healthcare Coalition is asking for. Do I have it all? I think from what we've heard today. Mike Fisher? I knew you'd want to come up.
You can offer me the chair.
I did not testify the other day on the deemed licensure
Right.
issue.
So this is the page 8 section,
Bottom of page 8.
bottom of page 8.
And just to say, we do licensure as a public protection effort for all kinds of reasons. And I think I would say something very similar to what I said about the sections. I did testify about last time that permissive is good here. I agree with Blue Cross's position here. But I think I would go a little bit further. I think deeming people to have met licensure raises all kinds of concerns, public health concerns.
Okay. Thank you. Anything else?
If I didn't say it already, Mike Fisher, healthcare advocate.
Right, so actually, let's stay there. So can you describe, let's go back and talk about, and I don't know if this is you, so if it's not, don't, just tell me, but the terminology of deem and how that applies to what we're talking about. Do you want to tackle that, or do you want us to have the coalition come back? Or let's talk about it, okay.
Yeah, generally.
Do you want to take the chair?
Sure.
That'd be great.
Thank you for that, because I even had to Google.
I have no idea.
It's like, that was like
I got lost totally in that.
Jennifer Carvey, Legislative Counsel. Yeah, I think the term deemed licensure is being used as sort of a shorthand for this section, but you can see if you look on page 6 of draft 2.2 under regulation of professions. This is section 17 of the original Act 91. It's around OPR and Board of Medical Practice and out-of-state healthcare professionals. And it starts out by saying, notwithstanding anything in Vermont's professional licensing statutes or rules to the contrary, through a date certain, in this case, the bill would move that out to March 31st of next year, a healthcare professional who holds a valid license, certificate, or registration to provide healthcare services in any other U.S. jurisdiction, and for a moment, we'll not get into the yellow language, shall be deemed to be licensed, certified, or registered to provide healthcare services to a patient in Vermont. So we're, for a time-limited period, Vermont law, and this has been going back for a few years now during the pandemic, has really treated out-of-state licensure as the equivalent of, or as the same as Vermont licensure for these healthcare professionals. And as long as they are licensed, certified, or registered in good standing in the other places in the US where they hold their license, I'm just going to say license, it's license, certificate, and registration, they're not subject to any professional disciplinary proceedings in any other jurisdiction, US jurisdiction, and they're not affirmatively barred from practice in Vermont for reasons of fraud or abuse, patient care, or public safety. And then it has information about how they would register, provide their information to the Board of Medical Practice or OPR, depending on the jurisdiction. And then also for our purposes in subsection C, a healthcare professional who is delivering healthcare services in Vermont pursuant to subsection A, pursuant to that deemed licensure, shall be subject to the imputed jurisdiction of the Board of Medical Practice or OPR as applicable. So what this is saying is we're going to treat people who are licensed in other states like they're licensed in Vermont, and we're going to exercise the same regulatory authority over them that we would have if they were licensed in Vermont. So this is kind of expanding Vermont's healthcare provider workforce during this increased time of medical need. So that's what the deemed licensure piece is. That has been in effect and is currently in effect. And if you move forward with what is proposed in here, would continue to be in effect through March 31st of 2024. The specific piece I think you're being talked to about today is that language on the bottom of page 8. And that's in there because the Provider Coalition had asked you to put it in there. It's in yellow because it was new and for your consideration. And this language says that healthcare facilities, health insurers, and Vermont Medicaid shall consider that deemed licensure as sufficient to meet the applicable Vermont licensure requirements for purposes of credentialing healthcare professionals and enrolling them in. So the credentialing and enrollment is whether they can bill as a Vermont provider and whether they can work in a Vermont facility as a Vermont provider. So it's saying if we've deemed them as licensed for purposes of delivering services here, they should be deemed as licensed or as Vermont licensed for purposes of meeting Vermont credentialing and enrollment requirements for health insurers and facilities. So it's a step further than you have done so far during COVID.
So it is a step further. I think that's what
it is a step further. I think some of it may be happening and some may not be happening, but there is not a direct correlation between deemed licensure for professional regulatory purposes and deemed licensure for purposes of meeting Vermont's insurers or Medicaid's requirements for Vermont licensure or the healthcare facilities for somebody to be Vermont licensed. So I think it has not been necessarily treated as equivalent to a Vermont licensed provider. And that's what the Provider Coalition is asking you to put in here. And I think you're hearing from Blue Cross, they'd be happy to think about it, but they don't want to be required.
Right.
And I think that's so far the only.
And so just to confirm, that is not, so that's a new section, the section on page 6 that's highlighted is separate.
The language on page 6 that is highlighted is a proposal to narrow the scope of who can have deemed licensure to those providers who are licensed either by the Board of Medical Practice or by OPR, but only OPR professions for which there is not a pathway to provisional licensure. So OPR, I think, has asked if we've already figured out another way to get those people practicing in Vermont and subject to Vermont regulation, then don't let them come in the deemed licensure door, have them come in the provisional licensure door.
Listen.
So nothing requires health insurers, health facilities, Medicaid to actually credential and enroll. I mean, they can make the decision to not credential someone.
Any individual provider?
An individual provider. I mean, because they credential people on lots of criteria. Isn't this just saying that this deemed license should not be a barrier for enrollment or credentialing? It doesn't mean that they have to credential or enroll them.
Right. I certainly would defer to the carriers and DFR for how credentialing, the specifics of how credentialing works. But I believe you're right that there are likely multiple criteria, but one of them is to be licensed in Vermont. And this is telling them, this proposed language on page 8 is telling them if the person is deemed licensed, then they need to meet that criteria. Doesn't mean the rest of the criteria wouldn't apply, but I'm not sure what those are.
Does DFR or Blue Cross Blue Shield want to comment?
No comment.
Okay. So think I would want to hear from the Healthcare Coalition again as to why, and I apologize because I think for some of this testimony, when they weren't here before, I was not here. So if other people have thoughts about this, I'm happy to hear them. Otherwise, I think I'd like to have them come back. And
Lori?
the Healthcare Coalition who's requesting,
Oh, yeah, okay.
the folks who are requesting this language. Okay, Leslie?
Yeah, just help me with some clarity on, we never had deemed licensure before. This is totally new.
This was new for the pandemic, so this has been in place since 2020.
Deemed I don't remember seeing deemed before, so that's what
This has been in here, but we may have been focusing more on the dates and
Zoom and.
making some other revisions in here. But yes, this deemed licensure language has been in here since 2020.
So what are we gaining by adding this section if it's been here all along? What's changed?
So the only things that would be different in this section 17 are the date extension and then these pieces that are highlighted. So you've been asked to make some modifications to what is in the existing, not just extend the existing deemed licensure provisions, but make some revisions, one of them being around the provisional licensure professions in OPR, and the other being this requirement that that payers and facilities take that deemed licensure as sufficient to meet their Vermont licensure requirement.
And that's what's new.
That's what's new.
Got it. Thank you.
Mike?
So Mike Fisher, healthcare advocate, happy to, so never good to be thinking on the fly in this thing. So, but I think Representative Black's question did clarify something for me here. We're extending the amount of time that we're able to recognize people in good standing from other states to practice here in the earlier part of the bill. Mm-hmm. And this part here is saying, hey, if that's the case, that sort of deeming of being able to practice here can satisfy that part of the Medicaid or health insurers
Credentialing requirement, yep.
process.
Yeah, it says, and therefore they have to do that too. And is that?
Therefore, who has to do what?
The insurers.
And I'll just say, we certainly wouldn't want, from the consumer's perspective, we certainly don't want to say, hey, you can practice here, but you're not going to get third-party reimbursement. Hey, consumer, you're not going to get third-party reimbursement for that care. So I'm gonna.
So are you changing your position?
I'm backing off in sort of in the strength of my position, because it seems to be that I think it might make sense to be explicit here. It seems to me like the payer still has authority to determine whether this person meets their requirements.
And I don't know if there's an impact if somebody is not, if an out-of-state provider practicing here under the deemed licensure is not credentialed by a payer, if that makes them out of network. I don't know, Sarah, if you know.
Yeah.
I think they can't bill.
They can't bill.
Okay.
Thank you.
And so I think thank you for that clarification. And all of this goes back to the fact that although we're not in the pandemic like we were, we do still have a workforce issue, partly due to COVID. And we are still struggling in our hospitals with people who are in with COVID. And
Know that for sure, Laura?
yes, we still have people that are in our hospitals with COVID, yes. We can get some numbers for you if you'd like them.
Yeah, I'd like to see those numbers, actually.
So the clarification from Mike, Mike Fisher, healthcare advocate, does that help people understand this? Do we still want to hear from the Healthcare Coalition?
Wouldn't hurt.
Okay.
I think what's confusing me, and I'm sorry to.
No, go ahead.
Is that this isn't what was there before, right? I mean, that deemed people were not getting reimbursed. Is that what I'm understanding?
Before what?
Before we added this, that this was necessary because.
I think that's what you should hear from the Provider Coalition about. I mean, I think Sarah's clarification that they can't bill if they're not credentialed. I don't know how prevalent that is, or the extent to which these deemed providers are not currently being credentialed.
Right. All right, let's hear back from the Healthcare Coalition on this one, definitely, because we still have to hear back from a couple other people anyway, so that makes sense. Okay, so I put that down, and then when we hear from them, all right, I will make sure they come forward with the numbers of what we're seeing today with COVID still.
Yeah, it'd just be interesting to see what the numbers are statewide with that.
Yeah, definitely. Okay, thank you, Jen. Thank you, Mike. So that actually was a lot faster than I thought. And so we are gonna have time to do other things that we need to do. We have no more testimony for this morning. And so we will be back here at 1 o'clock to talk about the blueprint. So with this time, it would, if you have a couple minutes, look under the budget documents on our committee page. If you need to find them, Daisy or Claire can help you find them, and read about the blueprint proposal. And even maybe go back and read the blueprints presentation when they came in to do an introduction. That might help us set the stage for our conversation at 1 o'clock, where we'll dive into